All right, I guess that means that we can get started. Hi, everyone. Thank you for coming to today's MAPP Rounds. My name is Clara Vila, and I'm a neuropsychologist at Mass General Hospital and instructor at HMS. We're very excited today to have Dr. Caldwell with us. And she is a neuropsychologist and director of the Women Alzheimer's Movement Prevention Center at Cleveland Clinic. She earned her bachelor's degree at Princeton University and her Ph.D. in clinical psychology with a minor in neuroscience at the University of Wisconsin at Madison. She completed her predoctoral internship at Harvard University, MGH, so right here, and postdoctoral fellowship in neuropsychology and neuroimaging at Brown University. Dr. Caldwell runs the world's only clinic aimed at helping women to reduce the risk of dementia by making sustainable lifestyle changes. She's also passionate about research on ways men and women differ when it comes to Alzheimer's disease. She's the principal investigator on R01 grants from the National Institute on Aging, National Institute of Neurological Disorders and Stroke, and National Institute of General Medical Sciences. And today, she will present on sex and gender in Alzheimer's disease risk and resilience, research and clinical application. We look forward to her presentation. And just so you know, we will have a Q&A at the end of the presentation. So please put your comments and questions in the Q&A. And the floor is yours. Thank you.
Thank you very much. And I want to say thank you to Dr. Quiroz and the organizers and folks at the MAPP. I'm really honored to be here today to talk about sex and gender and Alzheimer's risk and resilience. My funding is listed here. And the objectives for my talk today are to review current factors linked to sex and gender-based Alzheimer's risk, identify unknowns in women's Alzheimer's risk in this literature, and then to discuss ways to support women's resilience. So to start out, what are sex and gender? When I use these terms, what I'm referring to by sex is a biological variable defined by characteristics encoded in DNA. In contrast, what I mean by gender is a social construct that refers to the way that we show ourselves and present ourselves as men, women, or gender diverse individuals, and the way that the world perceives us and treats us in turn because of those perceptions. Sex and gender are separate types of concepts, but they're also interrelated. On this slide, I'm showing on the left a list of factors that are either based or influenced by sex, and these include hormones, chromosomes, and the way our body and our brains respond when we're exposed to stress. In contrast, on the right, I'm showing some factors that are influenced by gender. For example, the way society has particular expectations of what we will do and how we will act, opportunities that we're presented with or excluded from, and the types of stressful experiences that we may be more likely to be exposed to. Why should we consider sex and gender in research more broadly? At a broad level, it's just good research practice. And if we're NIH funded, it's also necessary. So it has been about 8 years since NIH put out a mandate on sex as a biological variable. This policy states that NIH-funded researchers must consider sex when they're designing studies, collect data regarding sex, actually analyze that data, and then report and publish on that data. So this mandate has been present for quite some time. How are we doing given that mandate? Unfortunately, in many areas of research, there's a big lag in terms of whether or not we're looking at sex differences and whether or not we're reporting on them. I'm showing here a manuscript excerpt where researchers looked at 720 papers published in 34 biology journals, so slightly different field than mine. But what they found is shown in these two bars. The top bar is what the papers look like in 2009. And what you'll see is in red, just over 25% of the papers included both sexes. And this includes both human research and animal research. And there's a sizable number of papers in gray that don't report on sex at all in terms of inclusion. These hashed lines here within the red bar indicate the number of studies, only about 13%, that actually used analyses that would be appropriate for picking up sex differences. So now in intervening, we've had that sex as a biological variable policy. And in 2019, we do have a lot more studies that are including both sexes in red, almost 50%, and we have fewer studies not describing sex at all. But still, when it comes to using analyses that would actually be appropriate for discovering sex differences, fewer than 25% of studies in 2019 did that in this study. So what about a bit closer to home with most of our research? I'm showing here a recent paper from a group that looked at whether or not sex was being analyzed correctly and reported on in Alzheimer's disease clinical trials. So what I'm not showing here is that women are actually overrepresented in the clinical trials that were examined in this study. But unfortunately, on the left, this graph shows the probability that a study would actually describe sex-based analyses in the methods section. And the probability is around 0.5. So 50% chance of showing a sex-related analysis strategy. In the results of these papers, the picture is even worse. So probability of 0.4 that you'll hear about the results of sex-related analyses in the results section. So we have a long way to go in this field. But why is it important specifically to look at sex and gender when it comes to Alzheimer's disease from a methodological perspective, from a theoretical perspective? By now, we have a good amount of research on sex differences and gender effects in Alzheimer's disease. We know from these studies that sex impacts Alzheimer's disease diagnosis, prognosis, and risk. And we are starting to get suggestions that it may impact Alzheimer's treatment as well. Okay. When it comes to diagnosis, what we know is that 2/3 of people currently diagnosed with Alzheimer's disease are women. The picture is even more serious for women of color, including Black women who are at double the risk for Alzheimer's compared to white women, and Hispanic women who are at 1.5 times the risk compared to non-Hispanic white women. We are not only diagnosed more frequently with Alzheimer's disease, but we also decline faster after we are diagnosed. I'm showing here a figure from Dr. Rachel Buckley, a paper that she wrote in 2018. And this modified figure shows people who are amyloid positive across 3 very large research cohorts, the ADNI, the ABLE, and the Harvard Aging and Brain Study. And what this figure shows is that at the baseline of the study, women in pink are outperforming men in blue on a cognitive composite that includes memory ability. But women decline faster, so that by about 5 years into the study, women are now performing less well than men are. So part of the reason that women may appear to decline faster with Alzheimer's is that we are very likely diagnosed later. So I'm showing here on this right-hand panel some data from our memory clinic in Las Vegas. This is more than 550 people who came in with a concern about their memory. These are people aged 70 to 79. And what you'll see is in women on the left, in these blue bars, these are verbal learning on a list learning test and verbal memory recall after half an hour. Women outperform men over here on the right. There was no difference in the orange bars, which are nonverbal memory. So the reason that this might contribute to late diagnosis in women is these verbal memory tests are things neuropsychologists use as part of making that diagnosis of Alzheimer's disease. And the fact that in our paper, this finding was driven by people to 79 years old, this is the age period when a lot of people are first presenting with symptoms in a clinic. So we are not going to be able to pick up women as easily as we are going to be able to pick up men. One valid criticism of this paper, as well as many others in this space, is that in our clinic, this is a highly white non-Hispanic sample. So do these findings generalize? I'm happy to say that many other groups are looking at this, and in particular, Dr. Jennifer Manley's group at Columbia has shown these kind of effects in more diverse samples. And I'll show one additional replication here. This is from work my group is currently undertaking in partnership with Dr. Sid O'Brien and his Health and Aging Brain Study. This is a sample from Texas of people who self-identify as non-Hispanic white or Mexican American. And in fact, we replicated that finding of women outperforming men, both in the non-Hispanic white group and Mexican American women. So this advantage in verbal memory is likely impacting diagnosis across race and ethnicity. So as much as it pains me as a neuropsychologist, maybe the problem is that we're too reliant on these paper and pencil type tests. And maybe to pick up women, we need to turn to things like blood-based biomarkers. Unfortunately, there are some sex and gender-based issues that can come up here as well. I'm showing now an image from a recent paper in Nature Medicine that reviews the fact that Alzheimer's disease blood-based biomarkers may have some sex-based impact. So in particular, p-tau181 and p-tau217, which are blood-based biomarkers of Alzheimer's risk or diagnosis potential uses, they are increased by brain Alzheimer's pathology, but they are also increased by medical comorbidities. So chronic kidney disease, high blood pressure, strokes, and heart attacks, all of these factors can also increase tau in the blood. And unfortunately, women are more likely to have some of these conditions, including chronic kidney disease. So could these blood-based tests be able to pick up more women? Absolutely. But what we don't know is whether or not a lot of those people we pick up, those women we pick up, might be a false positive if we're not controlling for some of these comorbidities. Then finally in this space, what happens when it comes to treatment of Alzheimer's disease? I'm going to show just two examples from recent medication treatments for Alzheimer's disease that are disease modifying. So these are the two recently FDA approved drugs that actually change amyloid, take amyloid plaques out of the brain. This is a figure from the eMERGE study from aducanumab. And what you can see in the box that I'm highlighting, women are the top bar in that box, men are the bottom. And women are not benefiting as much as men from this treatment in terms of impact on cognition, clinical outcomes. And the same picture is observed for lecanemab. This is from Eisai. And you can see here, women are the top bar, men the bottom. And again, women not having as much of a convincing effect when it comes to clinical outcomes surrounding memory. Okay, so what is it that actually puts women at risk for these poor outcomes, for different treatment responses, for later diagnosis? In the past, it was thought that women on average live longer than men, and that was the entire story about Alzheimer's disease prevalence differences, because just getting older is the #1 risk for Alzheimer's. At this point, we know that that is not the entire story. It is an important part of the story, but there are many other factors that impact a woman's likelihood or risk for getting Alzheimer's disease and dementia. I'm showing just a few of those on this slide. Some factors on this slide are things that are present in both men and women, like having a copy of the APOE4 allele, the most common risk gene for late onset Alzheimer's, or having diabetes. And while these are present in both men and women, they seem to have a differential effect on women in terms of dementia risk. Other things on this slide, like depression, physical activity levels, and education, concern things that are more frequently observed in women. So higher rates of depression in women, lower levels of physical activity, and in the cohort of women who are currently being diagnosed with dementia, oftentimes also lower educational opportunities, all of which could potentially go into that equation, which is our Alzheimer's risk. Finally, there are some factors listed here that only women or people with uteruses experience, and this one is menopause, which is an area of high interest in terms of women's Alzheimer's and dementia risk right now, and I will touch more on that one later in particular. So because there are so many different factors that can impact women's risk, I'm not going to go into depth on all of them, but I will go into a bit more depth on some of them. So I mentioned our genetics. So men and women can both have a copy of that APOE4 allele, which increases our risk for Alzheimer's over someone who does not have that genetic risk. In a woman, studies show that that can increase our risk up to 4 times more than it increases a man's risk having that single copy. In terms of medical comorbidities, again, diabetes happens in both women and men, but before age 70, people with diabetes show a similar picture regarding memory as people without diabetes. So women are outperforming men. After age 70, though, women with diabetes are showing more detrimental effects on their brain health. So worse memory decline and more brain atrophy compared to men. Cardiovascular disease is another common risk for dementia and brain-based memory changes. And so when a woman has a cardiovascular disease, what studies have shown is that she is at 1.5 times greater risk than a man with cardiovascular disease when it comes to getting dementia later. Finally, on this slide, what about lifestyle? I mentioned physical activity, which is a direct risk for dementia and Alzheimer's disease, and we know that women are twice as likely to be sedentary as men. Cognitive activity is also an important factor. We know that cognitive activity supports our brain health and aging, and in men, if men are cognitively sedentary, they are 1.7 times more likely than men who have an active cognitive learning life to go on to get dementia. And the picture is worse for women. So a woman who is not cognitively active is 2.6 times more likely to go on to a dementia syndrome. So I think it's important that a lot of these things on the last couple of slides I've shown are things that we can modify. The reason why I'm calling them modifiable or life-based risks is that there are 12 items that are listed on this slide that have been shown by a series of research investigations to account for up to 40% of current dementia diagnoses. In theory, all of these are modifiable or preventable, although some of them we may have more or less control over. Of course, though, this paper and the series of papers where we're talking about modifiability and prevention, this is for men and women altogether. So more recently, researchers have started to look at what happens if we try to think about modifiability of dementia risks when we separate men and women. At least in this sample I'm showing on this slide, men actually have a higher percentage of cases of dementia that seem to be accounted for by these modifiable risks. But when it comes to particular risks, they're accounting for more cases in women. So 2 of those are physical activity and depression. Another important thing to know about these modifiable risks, lifestyle-based risks, they're thought to be most impactful at particular life stages. So at left here, I have this reverse S curve, and at the top in green, there's less education. It's thought that having a lower education level early in life has impact on dementia risk later. In contrast, in the middle in blue, things like obesity and high blood pressure are thought to have most impact on dementia risk if they happen at midlife. Then finally, in purple, these are factors including diabetes, low physical activity, and depression that are thought to have an impact on dementia risk if they're occurring late in life. Just like with the percentage of modifiable risk that is attributed, though, could all of these risks in terms of their timing have a different picture if we looked at them separated by sex? This is an open question. And since this is an open question, it's also an open question about intervention. So if we happen to take men and women separately, might it matter more for a woman to intervene on depression earlier in life when it comes to dementia risk? It's unknown. So here I'm showing a snippet of data from the research registry in my clinic. And so I'm doing this because these large studies, there's a bit of it's a population approach. We're seeing what risks account for current dementia. And my question early on in this clinic that I run for women who are at risk for dementia based on their family history was, what risks are actually most common? What risks are coming through the door? And of course, this is a biased sample because these are women who are very motivated to reduce lifestyle-based risks. And they tend to be educated on dementia, maybe more so than the general population. But even with that taken into account, I think as a clinical psychologist that it's really striking what the risks that are most common are. Alcohol use. So this is not an alcohol use disorder, it's just endorsing alcohol use, but alcohol use in about 130 of 167 women. Almost half of the people walking through the door are depressed, and almost half are endorsing chronic stress. So even more than some of the medical risks that we're thinking about at midlife, we have some big potential psychosocial behavior and environmental exposure types of barriers to behavior change. Okay, so now I'm going to move away from some of these modifiable risks to talking about what menopause might be doing for women. So this is a very important and very active area of research. And so I'm going to just describe a few things that are ongoing. Menopause and Alzheimer's disease pathology have an interesting timing coincidence. So we know that the average age of menopause is in early 50s, about age 51 to 53. And average symptom onset presenting to clinics for Alzheimer's is often in the mid-70s. So if amyloid is building up a decade or two before that, for women, that puts us right around the time of menopause. And it's not just a timing coincidence. There have been numerous studies at this point that have looked at changes in women's memory and brain structure and function across the menopause transition. I'm just going to highlight a couple of findings here. One that I'm not showing an image for is that across the menopause transition, researchers have shown that memory takes a dip. So women are at their baseline. They go through the menopause transition, their memory is down from their baseline. They make it to postmenopause and memory recovers somewhat. And this does kind of validate a lot of the anecdotal feelings that women have about what it's like to go through menopause. You feel cognitively foggy, you're not as sharp. And then it's not just memory on paper, there's also brain structure and function changes that have been shown. One example is on this slide. This is from Dr. Lisa Mosconi's lab. At the top, I'm showing gray matter volume in the top two panels. And then row C and row D are white matter volume. And what you'll see is from pre to peri to post-menopause in several regions, very critical in Alzheimer's disease. So we're talking about temporal regions, the precuneus. We have a decrease in volume that doesn't recover, or a dip in volume that does recover. This paper also showed similar findings in function, but I won't show those today. What I will show is a modified excerpt from another one of Dr. Buckley's papers last year, which shows that it's not just a change in memory, structure, function. Menopause also seems to be a time of demarcation at which point, or after which point, men and women are starting to show differences in pathology of Alzheimer's disease or relevant to Alzheimer's disease. So these two images show two different brain regions, inferior parietal and rostral middle frontal, on tau PET. And what the take-home point is that if you look pre-menopause, women age matched to men don't show differences in tau. After menopause, women age matched to men show more tau in both of these regions. So menopause is a marking point. Why might this be? I'm showing now one of my favorite figures from a paper in 2015 that shows estrogen is good for memory and plasticity in real time. So this is a hippocampal pyramidal neuron across the mouse estrus cycle. And what this graph shows is that in these three call-out panels, when estrogen is high, we see more dendritic spines. And when estrogen is low in that cycle, fewer dendritic spines. So in real time, not at menopause, but just the level of fluctuation that occurs across the menstrual cycle, we have real-time evidence that estrogen is supporting a process that could lead to support in memory, like those verbal memory advantages we have over men. So in addition, estrogen isn't just good for plasticity, it's also directly anti-pathology when it comes to Alzheimer's pathology. This is data that comes from animal studies, mouse studies, and rat studies, and I'll just show three brief examples here. So on the right, this is a mouse model of glioblastoma in which amyloid beta is released. And what these researchers did was they gave progressively higher levels of estrogen and looked at what happened to amyloid in these mice. And there was a dose-dependent response where amyloid was reduced. Now, this is an excerpt from a mouse model of stroke. So what these researchers did was they induced a stroke and looked for tau hyperphosphorylation. In this middle column, this is a mouse who's had a stroke induced, and the bottom panel, panel E, if you can see that E, shows staining of tau, increase in tau compared to a mouse that didn't have a stroke. However, if the researchers pre-treated the mice with estrogen, we get less tau hyperphosphorylation. Finally, estrogen is also cell death avoidant. And so in this top panel here, these researchers looked at exposing neurons to amyloid. And what they found was that here's a control set of neurons. Green means healthy neurons are stained here. Amyloid is introduced, and what happens is you see less green because the neurons are dying. But if you take a set of neurons and pre-treat them with estrogen and then expose them to amyloid, you get a lot less cell death. So estrogen having a big effect on survival of cells. But estrogen is not the only thing that changes at menopause. So a couple of slides ago, I showed that messy graph, which had all sorts of hormone changes going all different directions. Another big hormonal change is FSH. So follicle stimulating hormone, rather than decreasing at the period of menopause, increases. And so some research has shown really promising potential for FSH as a mechanism. In particular, Zhang et al. Last year showed that in a mouse model of menopause, so if you take out the mice ovaries and look at whether amyloid and tau are building up, you will see this column is the overectomized mice. Amyloid builds up, tau builds up. But If you give the mice an FSH blocker, you don't let FSH rise after overectomy, you see much less amyloid, much less tau. Of course, we're concerned about women and females, but if it doesn't work in males, it probably isn't as useful a treatment. So the researchers also looked at a male mouse model of Alzheimer's disease. So they had APP PS1 mice, and you would expect that in the cortex and hippocampus of these mice, you should see a lot more amyloid beta 40 and 42, and they did, except if they gave them that FSH blocker, at which point both of those types of amyloid were reduced in both brain regions. So to this point in the talk, I've shown a lot of different risks for women for Alzheimer's, but also a lot of different potential resilience factors. I'm going to turn now to reconciling those two things. This is where of my own lab's work has focused. So I'll also share a couple of things from my lab. When I say reconciling, what I really mean is trying to figure out where it goes wrong for women. So we have this powerful estrogen throughout much of our lives. It's great for our brains, but then we lose it. So can't we just replace it if that's where things go wrong? We also have this great memory for much of our lives. We know it's there even after menopause because it's there at age 70 to 79. So there must be something else that's supporting that memory. What is it? And then we also know it's not a fail-safe. So at some point, whatever's supporting that memory, when Alzheimer's comes along, it fails. What is it? And then finally, there are so many different risks. What could we look for factors that might be common to more than one risk? And if we can find commonalities, how early can we see them? Maybe could we see them at midlife before women start to have pathology in their brains? And can we treat those commonalities? So I'll start with the bad news, and that's that we can't just put estrogen back in. Hormone therapy is not a universal cure for Alzheimer's disease. It's not an easy fix. This knowledge dates back to the Women's Health Initiative study, which showed that in more than 30,000 postmenopausal women who were introduced to hormone therapy, it was not, unfortunately, neuroprotective across the board. And in fact, the opposite was observed. Those women had increased mortality rates, high breast cancer, stroke, and dementia rates, including Alzheimer's disease, which ultimately ended this trial. At the same time, after this study was looked at more closely, most of those outcomes were seen in women who are older. So women who were long past menopause and were now having estrogen reintroduced into a system that had adjusted without it. At present, we've had a lot more detailed studies on this topic. We know a lot more, still not everything. The current data supports that if a woman is long past menopause, it could be detrimental or dangerous to start hormone therapy. But on the flip side, if a woman goes through menopause prematurely, for example, due to a surgery or a health condition requiring certain medications, replacing that estrogen can be critical, not just for health at that time, but for brain health and dementia risk and aging. The area that's least clear is around the time of menopause. So this has been called the potential window of opportunity. But if we look at the literature as a whole, trying to combine across animal studies, observational studies, retrospective studies, and clinical trials, we will see that some studies indicate that hormone therapy is great and for dementia risk. Some studies will indicate it increases dementia risk, and some show no effect. So here is where we need more work. And I think there are two questions that are particularly critical. One of those is who should be taking HRT, who might benefit most? And that question includes things like, is it women at risk for Alzheimer's? Is it certain genetic history? Is it certain body composition? Is it women who undergo or experience more types of menopause symptoms like hot flashes? So that's an open question. And the other one is, can we build a better hormone therapy? And by better, I mean one that actually gives us some of those later brain protective effects without some of these dangerous potential side effects in subgroups of women. So a lot of ongoing work done by excellent researchers, and hopefully we'll know more on that front within the coming years. Okay. But again, it's not just estrogen. We know that women have this memory advantage beyond menopause. So I'm showing now a couple of examples from my group where we've asked the question, what is it that could be supporting memory in women past menopause? Could it be brain structure differences from men or brain function differences from men? So I'm showing on this slide an example from my colleague, Dr. Filippo Sieri. And this is a paper where he asked the question, do women and men have differences in cortical thickness in Alzheimer's relevant regions? And if so, does that help women's memory? And that's what he found. So in several regions, including the precuneus and some aspects of temporal lobe, women showed thicker cortex. And among women, those with the thicker cortex had better verbal learning. Now I'm showing an example from another paper by Dr. Sieri, and this is the similar question asked about function. So do men and women have differences in the way that their brain at rest organizes its networks? And if so, does that help women's memory? What this paper showed was that women on average showed less efficient neural networks at rest. So globally, locally, and in terms of the centrality measures in their network, women were less efficient than men. And in this figure, this includes women who had normal cognition in the middle, MCI, and then on the outside, Alzheimer's disease. And for women with normal cognition, normal memory, what we found was that those who had better efficiency and better centrality, so they looked in terms of their network organization a bit more like the men did, they also had better memory. So a couple different ways we might be supporting that memory. Of course, it doesn't last forever. Now I'm showing the flip side. So what is it that increases women's vulnerability and makes things fall apart despite those resilience factors? So on this slide, I'm showing some of the work led by Dr. Sarah Banks, who looked at tau distribution in women across the Alzheimer's spectrum and how that related to memory. And what she showed at the top was that men on the left and women on the right had different distributions of tau buildup, and that in this subtraction at the bottom where women had more tau buildup, among women, those with more tau had worse memory. So, and this finding was driven by women with MCI. So compared to the last slide, we're seeing some resilience factors at play in normal cognition and some vulnerability factors that come into play by the time of MCI. But it's not just pathology that's reducing resilience or helping women to lose that memory advantage. I'm showing now a paper, an image from a paper by a different group. And this paper examined whether or not men and women had different modifiable risk prevalence throughout their lives. And there were some differences there. But the key takeaway for me is that if you looked at memory and you compared people at different levels or different numbers of risk factors, women outperformed men if they had no risk factors or one risk factor. But as soon as you went beyond one risk factor, it didn't matter what it was, women lost that memory advantage. So it seemed a bit fragile. Another type of environmental risk that's not on that list of modifiable risks is our neighborhood and what risks related to our neighborhood could do to our memory. I'm bringing back here that image I showed earlier where we found that self-described Mexican-American women outperform Mexican-American men on verbal learning and memory. We found that when we added in neighborhood disadvantage, so did your neighborhood have access to healthy food and healthcare and education? If you did not have those things, you quickly lost this advantage. And it was only true for Mexican-American women. So it's a lot of risk factors. Again, coming back to this idea, can we somehow take what we know about all of these different risk factors and vulnerabilities that seem to be hitting women's resilience pretty hard, and can we look for underlying factors? I'm bringing back here that slide that shows all the modifiable risks. And in bold this time, I'm showing those risks that have been shown to relate to inflammation. So they're a cause of inflammation, a correlate of inflammation, or a result of inflammation. And interestingly, we know as well that tau and amyloid have a bidirectional relationship with inflammation. Stress increases inflammation, estrogen decreases inflammation. So with that knowledge, my group began to ask this question: does inflammation reduce resilience as a potential underlying factor? So within one of our in-house longitudinal observational studies, we looked at whether or not women might have some particular effects of pro-inflammatory cytokines on their verbal learning and memory. And what we found was that inflammation did give a sex-specific vulnerability. So both at baseline of the study and 12 months later, on verbal learning in this top row and verbal delayed recall on the bottom row, women in purple outperformed men in blue, as we would expect, but only if they had low to moderate levels of IL-1 beta, or a marker of inflammation. At high levels, women lost that memory advantage in 3 out of 4 cases. So baseline learning, 12, and baseline delay, and 12-month delay. So my current research in my lab is focused on midlife as a time of potentially inflammation-related risks coinciding. So I have an R01 from the National Institute on Aging, and data collection is well underway, but hot underway, so no data yet. And what the question that we're asking is, in women at midlife, so 30 to 60, who have a family history of Alzheimer's, could it be true that sex and gender really have some strong effects for us? And in particular, will chronic stress across midlife, and especially stress that has links to our gender, so things like the types of chronic stressors we might be exposed to, family responsibilities, career responsibilities at the same time as family responsibilities, caring for aging parents with dementia, all the way on up to very serious chronic stressors or periodic stressors that women experience more often than men, such as assault. Could a history of those things and ongoing stress meet up with some of these factors that are sex influenced, like our drop in estrogen and the way that our HPA axis, our stress-related responding, and our immune function works at midlife? And could those things interact to lead us to have a phenotype of neural compensation that's actually overactivity, which might help us in the short run and hurt us in the long run? So neural overactivity or inefficiency, both at rest and while we're trying to learn. And might it also impact our periphery? So can we measure in the blood inflammation levels related to our estrogen loss and our stress increase that might act also as a phenotype combined into a really recognizable risk phenotype that might indicate that these women, among all others, are at risk for dementia and Alzheimer's later on? But not just a risk phenotype for the sake of identification, a risk phenotype that might lend itself really well to treatment, in particular, interventions that could reduce inflammation. So that's where we are right now, and I'm hopeful that I'll be able to share data on this at conferences soon. But to wrap up my talk today, I'm just going to go over a couple of nuggets of insight that I've gained from running this clinic, where women with a family history can come to change lifestyle factors over the past 3 years. And it's really, you know, as a clinical psychologist, I feel like I'm learning from the patients And the most valuable things that I see that I can do for patients and ways that I hope others will take on are really to change the way women think about aging and Alzheimer's. Many women think that Alzheimer's is inevitable, and they don't know that there are some of these lifestyle risks that they can control and change. Many women also are used to hearing that things like nutrition and exercise are in service of making their bodies look a certain way, and that is the primary message they've gotten all of their lives. And flipping that to change your nutrition, change your movement for your brain it can be a powerful flip. And then lastly, based on those gender-related societal expectations that on many women that we take care of everyone else and put ourselves last, sometimes it can be really hard to reduce our risks unless we have permission. And so giving that permission to prioritize yourself is something I think we can all do to help women. In addition, this work has really led me to go down a research rabbit hole where I've looked a lot at what supports treatment adherence, what supports behavior change. And we have to be, as providers, we have to be collaborators in this kind of change rather than an expert who's just giving a prescription. If we are not asking about women's stress, their sleep, depression symptoms, all of which are risk factors for poor cognitive outcomes and also major barriers to being able to change, I struggle to see the recommendations that I make as useful if women are not having these things addressed. And similarly, dollars. If we're making recommendations that are financially unrealistic, then they're not great recommendations. And kind of building on that, recommendations as a whole, they just need to meet reality. So if we as providers can work toward usable education, things women can put into play immediately, and to the extent we can, that they can do better, easier and faster, all of the more chance we're going to have of making an impact in actual women's lives. So I wanted to acknowledge my clinical team, my collaborators and support. I'm really lucky to work with the folks that I work with. And thank you all for your attention and for attending today, and to the organizers for having me.
All right, thank you so much, Dr. Caldwell. That was so comprehensive and interesting. I have a bunch of questions, but there's also some questions in the Q&A, so we'll be fair and get started with those. The first one is actually from Aditya, and he says, I love this idea of neural overactivity actually being to detriment when it comes to AD. There's some indication that ApoE4 carriers also show a similar compensation pattern for memory functioning. And so he asks us, do you think perhaps the combination of both factors is why women E4 carriers may show the sharpest decline in memory once these compensatory supports start failing?
Yes, I think that's a great track. It's something I've thought about a lot. And I think, the figure I didn't show from that Buckley paper in 2018 is that it's the E4 carriers that have that steepest decline. And, it's tough because I think when you try to combine sex and gender effects, it's not true that all women are going to have the same gender effects that they have gone through, or the same, for example, class-based effects that they have experienced. So I think that's a good starting point if we're going to drill down from women to other interactive factors that could cause the same sort of endpoint. I think looking at women with E4 is a great point to start.
Yeah, that's very interesting. There's also another question from Nelson. It says, amazing presentation. Just one question. How would you apply a resilience project into women in the developing countries?
This is an absolutely amazing question. And I think that I couldn't do that without having really deep knowledge of the population that I would be helping. So, and I'm saying this as someone who's intervening with and hearing that, women haven't had doctors listen to them about their menopause symptoms or ask them about them, or women who've had symptoms dismissed, women who have an environment that's not going to allow them to do certain types of lifestyle changes. And those I have some sense as a woman that I need to ask about them, and that I've got to take certain strategies to make sure I'm asking the questions that let me intervene. But if I don't have that knowledge in a developing country, I think that I'm not going to have the best intervention. So honestly, I think that resilience setup, you have to partner. So I would say if there's a location that wants to set up a women's program or a dementia risk reduction program, that it be driven by the medical community or the community at large in that location.
Yeah, that's very interesting. And just to add on that, some of the work that we've been doing with Dr. Caldwell as part of the diversity and disparities PIA has actually looked at some of those cultural and geographic factors and considerations that may change in different regions. And the first one would be to actually assess those sex-specific and gender-specific so that you can tailor those interventions that could be so helpful. So yeah. And there's another question from Rory. He says, thank you for a brilliant talk. The area deprivation index findings are really interesting. Do you know if there are similar effects of individual level SES, such as wealth, income, etc., on the memory advantage, or do you think that the effect is specific to community area level SES?
So I think these are plans for that sample, I guess I would say. So I think that, when we talk about things like sex, gender, race, ethnicity, I think it's, I kind of alluded to this before, but I think those are categories that you can consider as a category sometimes, but not everyone who belongs to that category has the same experience. So I think it's important to look within, if it's area deprivation index, yes, we also have to look at potentially just different aspects of SES. If you're in that area, but you have a higher income, could that protect you? Or any other various combination. I guess what I'm trying to say is those all need to be investigated. And I don't think this is going to be a simple process where we say, women who are Mexican American have this particular risk and it's only that one and that's the path. It's going to be more complex, which is why I think kind of trying to figure out if there are some underlying biological consequences of some of these risks that then we could kind of treat more than one risk with one treatment that's aimed at biology. I think that would really help us.
Yeah, great point. I'm not sure if there's another question at this time. I do have some though. I was actually, specifically given that you're a neuropsychologist, I was wondering if you could talk a little bit about, given the verbal memory advantage that you talked about, how do you think, or do you see the field moving into both clinically and research settings, the use of sex-specific norms or sex and gender-specific norms, or even a battery, and then also whether that could have an application as well in clinical trials and inclusion criteria?
Yes, yes to everything, I hope. So just one example, over the last couple of years, our memory clinic in Las Vegas, we wound up changing. It was a long process, a lot of debate, but now we use the Ray Auditory Verbal Learning Test, and we use age, sex, and education based norm that. And although there was a lot of debate, my bottom line really was, if I get dementia, what test do I want someone to use on me? And that's the test that I feel like would maybe pick it up in me if it was me. So I hope that clinically, our field has we've got so much work to do, I think, in neuropsychology on a lot of fronts. And I think we have to test these things out empirically and see, if we shift over to different types of norms, will we be able to more accurately diagnose folks we know we're missing right now? And of course, it's not a it's a nuanced conversation. There's a lot of things to consider in switching norms, but I'm in favor of making sure that we don't close that door just because we've always done something one way. And thinking about the whole battery is another interesting piece. I think for me, at least for those things that we've had decades worth of research showing that men and women have measurable differences, to the extent that those differences could impact diagnosis, I think we've got to consider it. And then in clinical trials, I mean, honestly, it scares me sometimes to think about that trial data where we're not testing for sex differences and we're not reporting on it, because it concerns me to think about a couple of things. And one is that, maybe women are just not going to get effective treatments. And on the other hand, maybe we as a whole are missing effective treatments because we're glossing over responses in men and women, which might be essentially suppressing an effect. So I'm hopeful that we're turning the tide, but there's a lot to be done.
Yes, and very exciting, I guess, to start thinking about these things and the applications for clinical trials, given some of the newer approvals. So windows of opportunity, I guess.
Yes.
Well, I could keep you here for another hour, but I will not do that to you or to those listening. But thank you so much for this great presentation. It has been such a treat, and yeah, and look forward to seeing more of your work.
Thank you so much. Thank you for everything.
No, thank you.